Good morning. Welcome to Barnsley CCG Governing Body Meeting Public. Welcome to members of the public that may see this, and send us answers. Welcome to Governing Body members. Thank you. So, Kay, housekeeping?
Yes, we're holding the meeting via Microsoft Teams this morning. So if we could just remind members to raise hands if they would like to ask a question, and if we could keep microphones muted, please, unless we're speaking.
Okay, thank you. Apologies?
I don't have any apologies.
Okay. Then we've got two people who've not been here before. One is Chris Edwards, our new accountable officer, shared with Rotherham. And the other one is Madwi, a new governing body member who has been with us in the past but may not know everybody. So if we could have a round of introductions, perhaps starting with you, Chris, then Madwi, and then we'll go around. Is that okay?
Yes, good morning, everybody. My name is Chris Millington. I would sit on the governing body.
Carry on, Chris.
And I'm a lay member. I tend to lead on public and patient engagement.
Thank you.
Shall I go next, Chair?
Yes, please.
Two Chris's is going to be confusing, I think, isn't it?
Well, it's, yeah.
So hello, everybody. I'm Chris Edwards. I'm the new accountable officer. So I'll be joint with between Rotherham and Barnsley. I officially started on the 1st of September, and I'm looking forward to working with you all.
Good morning. I'm Madhvi Guntumukla. I'm a GP at the Grove Medical Practice and Apollo Court Medical Centre. Worked as a governing body member before and joined back from the 1st of September.
Okay, so if we work round on the screen, Nigel.
I'm Nigel Bell, lay member for governance, chair of the audit committee, and also a conflict of interest guardian.
Thank you, Nigel. Jamie McGuinness.
Hello, I'm Jamie McInnes. I'm a GP at Dove Valley Practice. I'm the governing body member. I've got responsibility for frailty and children.
Thank you, Mark.
Mark Smith, GP governing body member and mental health lead.
Okay. Jeremy.
Hi there, I'm Jeremy Bard. I'm the Director Commissioner for the CCG.
Jane.
Good morning, I'm Jane Sivakumar. I'm the Chief Nurse for Barnsley CCG. I'm also the Caldecott Guardian.
Richard.
Yeah, morning, I'm Richard Walker, the Head of Governance and Assurance at the CCG.
Okay, so Jamie Wyke.
Sorry, I'm the Director of Strategic Planning at the CCG, and also take a lead on delivery and transformation.
Dr. Kadasha.
Hussein Kadasha, GP, governing body member, and also council lead for the CCG.
Dr. Addy Cunley.
Morning, Deborah Dekule. I'm a GP, a member of the governing body, and I take lead on ophthalmology, musculoskeletal department, and cardiovascular diseases.
Thank you. Mike.
I'm a retired colorectal surgeon who's a secondary care specialist on the governing body of the CCG.
Okay, Roxana.
I'm Roxana Naylor, Chief Finance Officer at the CCG.
Thank you. And Phil. Still with us. Okay. Kay, you're the most essential part of this operation.
Hi, I'm Kay Morgan, Governance and Assurance Manager for the CCG, and I take the notes of the meeting.
Thank you. Have I missed anybody? No, that's good. Okay. So thank you and welcome. So are we caught, Kay?
We are.
Good. So if we can move to item 4, Jane, please. Patient story.
Thanks, Chair. So today's patient story is told by Tony, who will describe his experience of sustaining an injury during the COVID-19 lockdown and how the short-term changes that we did have to make across health and social care during this time made it quite difficult for people to access services. So I'll hand you over to Tony, who will give his recollection of his story.
Hello, I'm Tony. I've been off work for a few weeks now with my knee. To be honest, I don't really know what to do next. So I've had to go back to work, but I can only do like this from home. So normally I do a lot of driving in my job up and down the country. I'm a health and safety site manager. Our firm works all over the place. So we all got furloughed at the beginning of the pandemic. Sites shut down just like that. We managed to get back open a month or so ago. It's been tough for a lot of places. Luckily, ours hasn't gone under, so we're just about hanging on at the minute. Only a couple of weeks ago, I've been back, and that's when my knee went. So I'm really struggling with it. Still can't walk on it properly, taking painkillers. But it's the not knowing that's worrying me the most, if I'm honest. I don't know when I'll be seen, let alone when I'll be fit enough to get back to work fully. With all this uncertainty around jobs, I can't afford to be out of work. I'm at my age. I did my knee in on a walk. We were a good way in. The ground must have been a bit uneven. And all of a sudden, my right knee just gave way. I thought it was nothing at first, just tried to keep going. Thought I could just work through it, but after half a dozen steps or so, I just came to a grinding halt. My girlfriend was with me. She offered to run home and get the car just to drive me home, but I'm saying no, it's okay, we'll just take it steady. But it took us nearly an hour to walk back. I was in agony every step of the way. So that night, my knee was really swollen and painful. So got some ice on it, took some ibuprofen, went to bed. Not that I got much sleep. I was in a lot of pain. The next day, my knee was really swollen and I could only, just about hobble around the house. I saw my neighbour was outside, went to talk to him. He could see how bad it was and he offered to run me up to the hospital. I mean, I was a bit worried about going to the hospital, due to COVID. So my girlfriend was fine to take me. We're in a bubble, so that felt fine. But I was nervous about going to the hospital with, the COVID situation. I got there, I felt safe. Hospital staff were wearing masks, gloves, aprons. I had to wear a mask and sterilize my hands before we went in. And there was some chairs stacked up in the waiting room, so only a small number of patients could wait, and everyone kept a safe distance. So I saw the A&E doctor. Examined me, and she said that I'd likely damaged my cartilage. So I was told to go and see my GP, as I may need a referral to orthopedics. I was a bit taken aback, as I thought I'd have had an X-ray or a scan or something. Anyway, I rang my doctors the following day, and that's when this going from one place to another thing started, and I'm still none the wiser. I got a referral to orthopedic outpatients, but couldn't get an MRI, as when I went there, my knee was too swollen. So they told me I needed an MRI, but I had to go back. So waited a few weeks, rang the secretary in orthopedic outpatients, and they said, ring MRI and check when you might get in. So I did that. MRI said they're working on a backlog from April, and they couldn't tell me when I'd get seen, but I should go back to orthopedics. So I called the secretary again, and she said, you'll need to talk to the consultant. She gave me the number. I rang. They said, you'll need to speak to the secretary and get her to send your notes through. So I did that, and I heard nothing. So I can't get any treatment until I get a scan, and I have no idea when that will be. Now, you can tell that they're trying to do their best. I'm not sure they actually know what's happening themselves. So I don't know, maybe it's because of COVID, or maybe I'm just not an emergency or something, but I can tell you that this is still very painful and it's not getting better. I'm worried about work now. I can sit here and I can do stuff on my laptop, but it is not the same as visiting sites. I don't know how much longer they'll be able to put up with me like this. I can't walk properly, and I certainly can't drive. So if someone could just explain what's happening and when, you sort of feel forgotten. And if I don't keep calling, will anyone call me?
Okay, thank you. So lots of these issues have been noted at governing body and in various work streams. But what I'd ask for, first of all, from governing body are immediate thoughts and reflections on that patient story, because lots in there. Chris Millington.
I did bring a word forward at a meeting over the last couple of weeks when I said frustration, and with my work within the community and through patient council, there is a definite frustration out there of people who are in a position that you just explained to us. It's the where, the when, and the how am I going to get sorted? And there are lots of people who feel they've sort of dropped into a big black hole somewhere, and who is going to get those people out? So as commissioners, as providers, eventually, it's something that we really have got to get our heads around to solve these problems for people, for sure.
Mike?
Yeah, I think the main thing is communication. I know with a lot of the referrals, certainly in the cancer area, some of the specialist nurses spent a lot of time communicating with patients so they know where they are. And I think the worst thing for any patient is not to know what's happening. I know certainly there is a great backlog on all things like the MRIs, and there doesn't seem to be the money in the system to be able to finance extra capacity to reduce the backlog. So I think at the moment it's very difficult to see where the system as a whole can go. But I think the main thing is communication.
Thank you. Dr. Addy Conley.
Thank you, Chair. I think one thing that comes up to me here is that some of the failings in the system, where patients have to be going from one place to another place to get information. At this, where we are at the moment, we should be able to have one point where patients can call, this is the issue, and they can make all the appropriate, investigations and questions, and come back to the patient that this is the answer that you're looking for, or this is the answer that we have at the moment, rather than the patient going from the X-ray department to the orthopedic consultant and back again. And I think that's a big failing in the system.
Okay, anyone else? Madhvi? And then Jamie. I was hoping you'd say something, Jamie. Madhvi? Madhvi?
Yeah, can you hear me? Thanks, Mike. Yes. Thanks, Nick. Yeah, so like Mike was saying, communication and also the disconnect between services. I think for me, yes, COVID probably is complicating things by actually making it really, the waiting times have gone up for everything. But I suppose this is a scenario which would happen even if it is non-COVID. And I think for me, the difference is if it's a real emergency, things get sorted really quickly. But when it is not, it's obviously an annoyance because patients are in pain, and obviously it's affecting their lifestyle and their work and etc. Of course, it's a big annoyance to them, but it's not sort of like a real emergency sort of thing. And this is where, of course, this is a scenario whether it is COVID or non-COVID. And I think the problem really is, like Dr. Adikunele was saying, there's sort of lack of one person as point of contact. It's a disconnect between services. And when patients get actually sent from one to another and just say, oh no, you need to ring that person or this person, and that's when the frustration starts, I think. So if it can be streamlined, it would be better for them. And of course, COVID is obviously complicating because the waiting times as it is have gone up.
Okay, thank you, Madhvi. Before I bring you in, Jamie, just to say on this point of failure of services, there is something that's very that's core to practice, isn't there, between healthcare professionals, and that is the patient shouldn't be the vehicle of communication. It should be between healthcare professionals and the patient included, so we all know where they are in the system. And the other communication thing is, first of all, if there are difficulties in the system, at some point somebody should have explained those to the patient and what their expectations are of the system where it currently is. But I know you've got quite a bit to add to this, Jamie.
Yeah, I think we're going to just reflect some of the things that have just been said to start. So I think COVID has played a part, and I think has led to some differential between different providers. So we're aware and are clear that there is different guidance coming out at different times, usually for the acute hospital first, about how they should work, how they should behave, followed by others. And I think that's led to some confusion for patients, but also for healthcare professionals across as to who is doing what. And I think that's something that we're trying to work through now. I think the issue of the long waits that Dr. Gunter Muckler just picked up as a result of COVID, they're there. I think the challenge is that the patients are perhaps not being given the clearest information. So there's something there about how we give the information. And the thing that struck me from the conversation, I think you've just picked this up about the vehicle of communication, Nick, is that in that story, every time that something needed to happen, even if it was an interaction between healthcare professionals, it would put back onto the patient. So you need to contact the consultant, but then the consultant needs the notes. The patient shouldn't have to go back to the secretary to ask the secretary to send the consultant their notes. So there's something in that, and I think I just wanted to say as part of our sort of recovery, the work that we're doing with so Jeremy and the team and the elective work, we need to sort that about the clear communication, clear messages for patients, common understanding, and we've pushed this back nationally as well to try and make sure that the things that are coming out from them do that, but we've got to try and get the pathways right. I think the other thing that we had, and is hopefully resolved now at the start of this process in referrals into the hospital, is referrals were being made, I think appropriately. They were being clinically assessed, and we have to understand that long waits are important to the patient, but clinical need is where the priority is currently sat, isn't it? So it's that's how we're prioritising. That's how the hospital and other services are being told to prioritise. But as we work through that, we've got to make sure that the patient at the start is aware and they know what happens. So when we started the process, referrals were going into the hospital. The patients were being given information that said, we're unable to see you at this time, and the referrals were being passed back into primary care, and the responsibility in effect was put back onto the patient, that when they felt the time was right or they needed to come back and represent, and I think that's caused some issues and some challenges in, and I think there's still something to do about that. That's changed now, so all referrals are being accepted by the trust. I think we need to make sure that the messages that are going to those patients about how long they're likely to be waiting, what's going to happen next, and what they should do if things get worse needs to be a bit clearer. So I think that's something we need to take forward.
Yeah, and I think all those points, and I think of reassurance to the public, is that this has been the inconsistency of messaging, even from one provider in different departments, has caused confusion. It's not allowed GPs to have a consistent message to share with patients at the point of referral. We have written to the provider, and we are meeting together in a planned care board where we're looking to get some consistency of approach, and we have identified that clear communication to the patient and to other healthcare professionals involved is key, so that the patient isn't ping-balled around the system and the process is as seamless as we can get it. A couple of other things that just popped into my head is that as a GP in Athersley, what I have seen is quite a lot of new exercise-related injury. So people are coming in with knee injuries from walking, they're coming in with pulled muscles, on cross trainers, doing body balance and various other things that they weren't doing previously. So there are a range of musculoskeletal things as we try to keep healthy during COVID. The other thing which put into my little bit for the AGM is that we have to recognise there is not just the risk of physical COVID, but the total effect of COVID on people's emotional well-being, on meeting with the families, the effect that the uncertainty around jobs is having for the public, both those furloughed, those employed by small businesses, those that just don't know if they're going to have a job when they go back. And the other thing that's added to this was this last summer's experience for our young population around GCSE and A-level results, which also hopefully all our young people have got where they need to go and got what they wanted. That created some additional anxieties, so quite a lot to do. So thank you for that, Tony. Is there? I can see Madhvi, your hand is up. Is that up again? Something you want to add, Madhvi?
No, I'm fine, thanks, Nick.
Okay, so put your hand down, and I think if there's nothing else, thank you, Tony, and thank you for everyone's contribution, and we'll move on. Thank you.
Thank you.
So if we can now move on to item 5, declarations of interest. Any new to update? I think Chris and Madhvi have updated. Is that right, Richard?
Yeah, so we've included Chris's in the actual report, yeah. Madhvi. We have collected the declarations, but not in time to include it in the report.
Okay. Is there anything anybody else wishes to update us on or share before we move on? Okay, that's fine. Thank you. So item 6, Richard, questions from the public.
So we do, now that we're doing our governing bodies in teams, obviously we do give members of the public the opportunity to email in questions in advance. I can confirm for the minutes that we have not received any questions in advance of this meeting today. Okay, so we'll move on then to item 7, patient and public involvement activity report. Chris Millington, are you doing this?
Yes, I'll take this, Chair. Thank you.
Thank you.
The Engagement and Equality Committee have asked that I bring the recommendations contained within the National Voices 5 Principles letter to the governing body. The 3 key priorities included within their letter detail the 3rd phase responses that follows. 1 is shared focus on returning to near normal pre-COVID-19 activity levels for health services. 2, preparation for winter pressures with a view of further possible local and national COVID spikes. And 3, locking in beneficial changes and learning lessons from the first COVID-19 spike with an explicit focus on support for staff and taking action on inequalities and prevention. For the members of the public, National Voices is a leading coalition of health and care charities in England. Having read the letters and the recommendations, it brings home to me a statement that you will all have heard in recent pasts, which is nothing about me without me. We've been through and still are going through a worldwide problem called COVID-19. It has focused all of our minds into doing things differently, which in turn has created new opportunities for us all. Dare I say, new ways of working. And yes, we are now moving into a different phase. Let's call it the next phase. National Voices have heard from hundreds of organisations who have access to the voice of the people through all sorts of organisations. One that you would readily understand is something called Health Watch, but there are many more as well. It pointedly reminds us that also that there are still over 2 million people who are at home shielding themselves from potential effects of this virus. The spotlight is firmly pointed at our ability to listen and to learn. And there is now an ask of all health providers to focus on 5 key issues. I will take us through those key issues, and I'll add a little bit of subtext to explain some of it. So the 5 asks of us is: 1, engage with those most affected by changes brought about by COVID-19. People have a right to be consulted. 2, make everyone matter. Leave no one behind. All lives, all people matter in all circumstances. Number 3, this really got me thinking, and if there's out of the 5 points, this one really hit home to me, and it is confront inequality head on. And the comment is, we are all in the same storm, but not in the same boat. And that really has resonated with me, and it's something that I will continue to push all of us, me included, through patient council, through my interaction with people. And it's painted a picture in my mind that I will keep for sure. 4, recognize people, not categories, which means a personalized approach to how people want to live. And finally, number 5, value health and care by supporting both equally. So people living with ill health or disability need more than medicine. We've proven this via our own well-established My Best Life. We know that we've helped an awful amount of people in Barnsley, not by giving them pills, but by opening up things that they were already doing. We've demonstrated the real benefits of talking to people of the people of Barnsley through Barnsley Patient Council. The attendees at these monthly meetings, their monthly events, have guided us through numerous changes in how we deliver services in Barnsley. Quite often they've said to me, stop, you need to rethink this, that proposal, whatever that proposal might be. And we have stopped and we have thought about it, and we have tweaked and changed things for services for the people of Barnsley. The benefit that, and I'll mention it again shortly, via listening to the people of Barnsley, when someone said, well, have you done such and such? We said, no, we haven't actually. And it was regarding our Breathe service, which I'm going to touch on very briefly shortly. And that was, we have tried very hard and we've worked very hard to get the voice of the people for our incoming new revised Breathe service, however it might end up. And the comment was, well, have you actually contacted the National Union of Mine Workers? And no, we hadn't. So that is the benefit, in my opinion, of taking account of these 5 principles that National Voices want us to focus on going into the next phase. So the next point I want to just highlight to you is developing respiratory services in Barnsley. The NHS has set out plans for the next 10 years, identifying respiratory conditions as a key priority. We in Barnsley are developing local respiratory services for adults. We want to use all the feedback that we gained up to now, and it is all about getting our patient reference groups to push that message through your own GP practices. I know 3 people who use this service, and I've directed those 3 people towards this particular questionnaire, and they have completed it. We are asking for feedback, and that feedback will shape our future plans for this new service. I'll say again, one of the benefits that I got out of Barnsley Patient Council, the last meeting, was people who are likely to be using this service, are still using this service, are maybe ex-miners and their families. Why don't you contact the National Union of Mine Workers, which we're doing, to see if they can help in getting a bigger and better voice for this new service. So that concludes my input this morning in relation to public and patient engagement.
Thank you, Chris. Anybody have any questions for Chris or comments? Jeremy.
Yep, just a comment on that. Also, just to say that we've taken the National Voices paper and recommendations to our partners across Barnsley as well. So our comms and engagement teams across Barnsley are committed to those principles, and we'll do our best as we move forward to make sure that we embed them in our comms and engagement strategy across Barnsley.
Thank you, Jeremy. That's great news.
So we've already supported the National Voices 5 principles, and what's really important, Jeremy, is that you've taken it to the partnership, because the third one talks about confronting inequality head on, and that's not easily or always in the gift of health. It's a system approach, starting with education, employment, the opportunities that a community has offered to it that a system can develop. So it's good that our system partners have also signed up to that. Thank you. With regard to the NUM, Chris, we have had some contact with the NUM, and it came from the local authority, and it was around supporting how death certificates are completed, because in the COVID environment, if you put COVID, which is acceptable, and the doctor certifying the death doesn't put as part of the cause of death pre-existing work-related illness, their benefits are really difficult to get. So we've supported that and asked our local medical committee to circulate that around to all primary care physicians. So just as a reminder. Okay, so if there are no further questions for Chris, we'll move on. So thank you, Chris. We move on to item 8, minutes of our meeting of the 9th of July, which are here for comment and approval. Take them as read. Does anybody have any comments or anything they wish to clarify? No? Okay, I can't see it. I can see 9 faces and I can see who else is on the call on the meeting, but I can't see any hands up, so we'll take those as approved. We'll move on to item 9, matters arising, where we review the completed and any outstanding actions. Anything anybody wants to pick up there? Jeremy?
Thanks, Chair. Just item 190909, neighbourhood teams breathe. This is ongoing, but that's complete because we've wrapped that process into our procurement.
Yep. Okay, and we talked, I don't know if, I think it was Chris last time. Sorry, Jamie, you've got your hand up. I'll come back to this. Jamie?
Yep, so it was just on page 3, so 20 or 312. There's 4 items there, and I think Julie has covered off around releasing time for care. Just in terms of the information about joint working, you know, we've got some stuff that we've shared recently around the SYB strategy that will be included next time we bring a report to governing body. So I think that item's complete. In terms of the last two which have not got updates, Dr. Link, I think we did go away and confirm that there can be some tailoring and adjustment to make sure that local services are mapped there, but we need to do that work with Dr. Link. There were adjustments. I think at the point of having the conversation, we were conscious that the COVID situation was just sort of picking up and starting, and we wondered whether there was flexibility in the system to reflect any changes as a result of COVID. And there were changes made to Dr. Link to make sure that referrals to of patients who were symptomatic of COVID went to the right place. So I think that's confirmed and done, and we can do some more work with Dr. Link, so that's closed. And then the item around social prescribing. So I looked back at the notes, and what this was about was sort of probably twofold. One being around the impact that the service had in terms of appointments with GPs, and whether patients, after they'd been supported by the social prescribing service and then discharged is probably the wrong word, but stopped that support, whether they then just reverted back and came back into practice. The July report, which I've just looked at, shows that the current average of patients who have been supported, the 3 months before they started with social prescribing, were having 6.3 appointments, sort of in a 3-month period, and the number that they're having in the sort of 3 months after is about half of that, so 3.2. So there is a positive impact there, and that's demonstrated. The other bit in there was around whether patients who are supported, or people who are supported by the social prescribing service, then following the period when they're discharged, then after a short period are re-referred and re-engage. We've not got numbers on that are shared as part of our contract information. We asked the question of the service to try to understand, and the feedback from them, although not backed up by numbers, was that they're not getting repeat referrals. So the patients who have been discharged, they're not being re-referred in 2-3 months later, not in numbers anyway. They might be isolated cases. So I think that gives us the position there. And there's a discussion this afternoon, and we've been having at management team around social prescribing as well. So I think that item is closed. Have we lost Nick?
I think we have.
I think we might have.
Can I ask you, Jamie, do we have one of the major things for social prescribing was the A&E attendances? Do we have any figures on the effect on that? Because we looked at the original Blackpool figures, that was a major area of benefit.
Yeah, so they're wrapped up in there, Mike, but I did. So yeah, apologies. Not as big. So when we looked at our numbers around in Blackpool, they worked with the top 50, and the number of attendances was huge. So they had people attending multiple times a day, and lots of them. The numbers in, I've not got the numbers in Running, but the numbers in Barnsley were a lot less than that, so the opportunity wasn't as great. So the July reports, specifically from the secondary care service, show that the numbers pre-engagement were probably around 2.5 times of the people that they were engaging with, and it's 1.5 times after. So over that 3-month period, so it's not as big an impact, but obviously we're starting from lower numbers. That service took a while, as we know, to get up and running, but it is now working with they get the most frequent. They get the top 200 attenders actually, and work through that. They also attend the high intensity user group. Some of the feedback that we get from the secondary care service is that some of the patients, because they're working on the top 200, there needs to be something about filtering. So some of the patients that they pick up are patients and they're not just social needs. Some of them have got quite high level mental health needs, and I think there's probably some work there that actually if people are in receipt of and being supported for medical mental health issues by some of them crisis services, then maybe social prescribing can't have the impact, because that's not where it was aimed at. It was supposed to be aimed at the people who sort of are not able to access formal services. So I think there's some work still to do with that service.
Yeah, but I think if there are other services where people like mental health repeatedly going to A&E, it would suggest that the support from there isn't correct, and maybe we need to look at other issues as well.
Yes, yeah, it's other services.
I think we've still lost Nick, our chair, haven't we? I'm okay to do the next agenda item. Do we have a deputy chair, Richard?
So Mr. Millington is the deputy chair. And
Chris, do you all right just to step in just while we wait for Nick to reconnect?
I think I've just reconnected.
Oh, welcome back, Nick.
I don't know what happened there. Where did we get to?
We're just coming on to the Chief Officer's report, Nick, if you want me to take that.
Yes, please. We'll be happy enough with matters arising then. That was fine, was it? Yeah. Okay, Chris.
Is that okay, everybody? Okay. So I haven't submitted a written report this time. I will look in future to submit a written report. So I'm just going to verbally update you on the key messages from my perspective. So since the governing body last met as a country, we've gone from an emergency level 4 to a level 3. Is we'll move out of a national command and control situation and move to organisational control. So for us and how we're operating within South Yorkshire probably won't be a big difference, but the national pace around things around setting up Nightingale hospitals, managing protective equipment, that's moved away to local management. Things like testing will still be coordinated on a national level, and all the infrastructure nationally hasn't been taken away. It's still ready to jump back into action should we go back to a level 4. So we need to make the most of this period on level 3. So what we've received is big communications around what the NHS are now calling phase 3. So phase 1 was the outbreak, phase 2 was the how the NHS cope with the surge, and then phase 3 is how the NHS is going to recover and reset. I won't give the details. I know Jeremy and Jamie are going to give the detail in the next agenda item. But the key thing for us is we'll need to provide a Barnsley plan about how we bring services back to normal in that period. The period we're talking about is from now until Christmas time. We'll need to get services back to normal. We'll need to catch up where possible on planned surgery. And we'll need to consider about how we have a full-scale flu vaccination for the wider cohort this year, and also prepare for any COVID vaccinations. So that's a big challenge for us. So the requirement is we come up with a Barnsley response, and then we'll make sure we link that in with our South Yorkshire partners to come up with a South Yorkshire and Bassett Law System response. So I won't go into any more detail on that, Chair, because I think Jamie and Jeremy are going to cover that later on in the agenda.
Okay. Thanks, Chris. I suppose we ought to ask, are there any questions for Chris? No. Okay. Let's move on then. Item 11, Jeremy, Jamie, COVID-19 response, recovery and reset, and casting our minds back to the patient story. This should assure us on some of those points going forward. So are you taking it, Jamie or Jeremy?
No, I'll kick it off.
Jeremy's going to do it.
I'll kick it off, but looking forward to colleagues chipping in.
Thank you.
So, so something we've been working on, obviously, on a day-by-day basis. So, working actively with partners on a reset plan for Barnsley. Huge amount of work going into that. It's not quite at a point where we're able to share it, but we will be sharing the full detail of that very shortly. And I think an ambition to make that really transparent to Barnsley in a place as a whole as well. I've got a few slides I'll take us through, if that's all right, if I can share. So can people see that now?
Yep.
Brilliant. So I'm going to take us through, has it moved on to slide 2?
Yes.
Excellent, thank you. So we've got a few things to take us through. We've only got 15 minutes or so, but just want to give us all a flavour of the things we're focusing on. So I've structured it in this way. And under item 4, I've given some examples of areas of key focus. And that is really where we're focusing on the efforts of our reset plan. There's a huge amount of work going into that across all the services that we oversee as the Commissioner for Barnsley. I picked out 3 areas just to touch base on with governing body today. So moving on, kind of general update on COVID-19. Chris has just touched on that. So we're seeing rates starting to rise again, daily cases nationally up above the 2,000 mark, mostly in young people. And so far we haven't yet seen an increase in people becoming severely ill and no increase in deaths to this point. However, just need to note that that situation is being reviewed on a daily basis, and I suppose the expectation is, even after the government's announcements yesterday about the additional social distancing measures that have been put in place, that we can expect these trends to continue, and we need to be ready to respond to those, which I think as a system we're in a much better place to do than we were back in March, April. Seeing a similar rise of cases in Barnsley, so cases rising from around 1 to 4 at the end of August. It was 10 to 20 when this surveillance report was pulled together. In the last couple of days, it's gone above 30, in fact, but it's very much in line with the national trend, and the increase in Barnsley is largely in children and young people and not associated with severe illness. And we're monitoring this closely, working as a system under the leadership of our Director of Public Health to make sure that we are able to respond and tackle local outbreaks as they arise. Chris also mentioned that there are different phases of recovery. We're currently in phase 3, that goes from August through to the end of March 21, and that's kind of our planning timeline for the moment. So we're thinking about up to Christmas in terms of maximising capacity and really opening the system back up. Need to wait and see whether or not we're going to have an increase in COVID and indeed other winter illnesses. And if that's the case, we will need to respond to that. And that's part of our thinking forward to March 21. And then from April 21 onwards, we will see more changes being announced nationally, and we're expecting those to be announced over the course of the autumn. So where are we now? So I think we still continue to, as health commissioners and health providers, and also with the local authority and other organisations, working together to coordinate service delivery and to maximise capacity. As I said, we're currently co-producing a comprehensive system reset plan, and when that's finalised, that will be shared. And we expect to have we've got a good first draft of that now. We expect to have something that's in a position to be shared for further discussion, the governing body, management team, and across our partners as well in the next 2 to 3 weeks. And I've got some examples of that which we're going to run through a little bit later. Also actively working together to maximise the availability and uptake for the winter flu vaccination programme. And critically, and this is something that we can't do just as a commissioner, we need to work with our partners on this to identify where there are constraints and risks in terms of opening services back up and around capacity and waiting lists and what we can do to mitigate those. And that really links into what Chris Millington was talking about, and back to our patient story as well, about being absolutely as clear as we can be to patients and citizens about what they can expect from our NHS over the next few months, and delivering those messages in a transparent and consistent way across Barnsley and across the care partners. Governing body will remember that we have agreed as a system 5 priorities, and these are where we've got some really key urgent pieces of work underway. Number 1 is obviously the ongoing management and recovery from COVID-19. Number 2 is to continue to support complex, vulnerable and shielded people, including our workforce. Number 3 is to understand the impacts of the epidemic, the hidden harm, where people haven't accessed services, and the wider socio-economic impacts of COVID-19. Number 4 is where we lock in some beneficial transformation. For instance, the uptake of digital has been very widespread, and some of that we're getting very positive messages about, but we recognise that it's not a solution that fits and works for everyone. So we have to be very measured in our approach to how we carry on rolling out our digital approach, but making sure we're not excluding any of our population by doing that. And also in priority 4 about our planned care coordination, how we work as a system to maximise capacity and be really clear about what we are providing, where we're providing it. And I think, provide an example around cancer, because I think we've taken that forward quickly, because cancer is such an important area for us all to make sure we are achieving as much as we can. And then number 5 is achieving financial balance, both organisationally and at a place as well within the integrated care system. So I'll quickly set out the asks of the phase 3 letter. So it's set out in a couple of different headings. One is around accelerating the return of health services. So we're just going to focus on the top line, the strap lines there. So that's about restoring the full operation of all cancer services, recover maximum elective activity, some challenging targets there, which we're all doing our best to deliver and achieve. Restore primary and community services, and expand and improve mental health and learning disability services. And the list set out beneath that is drawn directly from the phase 3 letter, and those are the areas of focus for us all as a system for the next few months. Then, of course, there's also preparation for winter. We need to prepare for a possible COVID resurgence. Haven't seen that yet. We're seeing a rise in cases, but that yet hasn't translated into increases, particularly in terms of hospital activity. And then, of course, winter planning for the stock, which we do every year. So it's making sure we have capacity, it's making sure we are doing everything we can to extend and see the uptake of our seasonal flu vaccination campaign. It's our expand our 1-1 offer, so it's talk before you walk, looking into how we utilise that, learning the lessons nationally and seeing what works and what doesn't. And also working with local authorities on resilient social care services. We've learnt such a huge amount about working with the local authority around discharge to assess, importance of reablement, and of course care homes over the last few months, and we want to make sure that we are taking all those lessons into account as much as we can. And then on workforce and on health inequalities, there are particular asks for us there as well. One thing I just would point out in terms of health inequalities, and it's part of the governing body ask at the end of this, is that on the right-hand side, there's a requirement to strengthen leadership and accountability with a named executive board member responsible for tackling inequalities in place by the end of September in every NHS organisation. So we will need, as an organisation, to determine who that should be for Barnsley CCG by the end of this month. Any questions to this point? I can't see hands, Nick, so...
I can't see any hands.
Yep.
So...
I'll move on then.
Okay, move on. So,
example 1, in terms of our reset plan, this is where we start to get into detail, so I'm not proposing to go through it in detail. So we're looking at cancer services and taking a very proactive approach as a commissioner, working with our system and also within the Cancer Alliance locally and across South Yorkshire and Bassett Law. And we are focusing actions in 2 ways. Firstly, we know who is already in the system and is waiting for care or in the process of being cared for. And we have a comprehensive programme in place to make sure that those people are managed in the best way possible and access to care is facilitated and they are able to receive all the care that they need. Secondly, we have I think a responsibility as a commissioner to reduce as much harm as possible from those who have not presented to this point, and we saw referrals drop off quite rapidly over the last few months. They're picking up again now, almost back to normal levels. But there was a time when people clearly weren't presenting for the care that they needed, and we have put in place an approach to identify cohorts or geographical areas where we've seen variations in referrals that we can't explain, working with the local authority and our area councils on then addressing those communities and putting out messages to make sure that people are aware that they are able to access the NHS services are open. We can work with people on transport issues and to reassure people that services are open and also safe as well. And in fact, the approach that we put forward there went to the SYB Cancer Alliance last week. That's kind of the Barnsley approach, and that was adopted by the Cancer Alliance, who are now adopting those principles across South Yorkshire and Bassetlaw. So I think the work we're doing there with our cancer lead for the CCG as well, I think is leading edge, actually. I think we should be proud of it, and look forward to giving more detail of that in the future and keeping updated on progress.
Jeremy, Mark Smith's got his hand up. I think Mark's got a question.
Yeah, one specific thing that seems to be a big block at the moment is colonoscopy waits. Is there anything specific being looked at there?
So, Jamie, do you want to come in there? Because we looked at this yesterday in terms of our planning targets for colonoscopy, and there was some optimism that they were going to get back to where we needed them.
Yeah. So we did, and Nick, you picked this up yesterday as well, didn't you? And asked the question of the trust, and I think there's some work going on across South Yorkshire and Bassetlaw to identify potentially additional capacity, use of other providers that's been used, and also different ways of working and different ways to sort of increase the space and allow more numbers to come through. So the hospital, Mike, are quite confident that they can create the capacity and allow the flow to get through, which means that they'll be able to deliver diagnostic services, including colonoscopy, by the end of the year, but at the level that they did in 1920. So that's the assurance that's given back to us.
They did say it would be hard work, but they felt they could achieve it. Thank you. John, you've got your hand up as well. John?
Yeah, got you. Just a couple of things, Jeremy. Expanding surgical capacity with the independent sector, finance and performance. We were told that one of our independent contractors won't be fulfilling their contract. I think to the tune of, I think Roxana was saying £600,000 by the end of the year. They'll be underperforming. So I'm not too confident about what they're doing. And secondly, back onto diagnostics, if we could flood the system with 2-week waits if we can't do an investigation beforehand, whether it's just a simple X-ray, ultrasound. Now, we're already getting messages on our symptoms. There's a 6 to 8 week wait for certain investigations. So I'm not really confident. We need to get a cast iron assurance from the hospital when these diagnostic facilities are going to come online properly, because otherwise people will just flood the 2-week wait.
Yeah, I completely agree with that. So we think this is so fundamentally important that we've got allocated additional resource from our commissioning team into working with the system, particularly with the hospital, on this area. So we're going to get routine reports which come through to management team, and we'll share those more widely as well, and obviously with our cancer leads. So this is a clear area of focus for us as a commissioner, making sure that we get the services delivered that we need to have delivered, and understanding from our providers where they are experiencing issues of capacity and working with them to mitigate them as far as we can. So we are taking it extremely seriously, John, and I think it's going to be challenging for all of us, but we're going to do our best to make sure that we are working closely with them and being really clear collectively about capacity, waiting lists, access, and constraints arising from those.
Thanks, Jeremy. I've got Roxana next, and then I think Mike wants to come in as well.
Yeah, I just wanted to pick up just on John's point, because actually the issue around the particular provider discussed at Finance and Performance Committee was in relation to the peak of COVID. So actually there were significant capacity issues there around making sure that it was clinically safe to carry out procedures. So I think it's probably a different issue as we move forward into reset and recovery.
Okay, thank you. Mike?
Yeah, I think colonoscopy is one of the bigger problems. And I think it's a good example of what the hospitals are doing, because before COVID, they were doing 2 lists a day with 5 patients on each. Mm-hmm. During the recovery, they've gone on to 3 lists a day but they could only do 3 patients on each, which meant that they were still below capacity. And trying to catch up, they were also doing weekend lists. I understand now they're able to go up to 4 a list, which means that they are actually doing more than they were before. So the number should be going down, but it's very difficult because the endoscopy list is inadequate, or it was inadequate before COVID, and now trying to put more through it puts more stress on it. And I think, as I say, they are doing everything they can to try and get rid of the backlog.
Thank you, Mike. John, have you put your hand up again? Okay, put it down then. Okay, Jamie, is your hand up?
Sorry, that's still up from before as well. It's gone.
Okay. So, Jeremy, do you want to carry on?
Carry on, thanks. So up next is continuing healthcare. Jane, these are words from you. I don't know whether you want to pick up this with governing body and just talk through the next couple of slides.
Of course, thanks, Jeremy. So as we know, some of the functions for continuing healthcare were paused through COVID, with the team picking up case management of our particularly vulnerable people who receive continuing healthcare. So on the 1st of September, it says that we should commence our recovery plan. In fact, our CHC team have started already, and that started in August to commence their recovery plan. Sitting behind this, we have a very comprehensive plan to deliver to sort out the backlog and also the new referrals that will come into the service, because obviously the business as usual will not stop. So we have 4 phases, with phase 1 to address the backlog, which we've already started to do. Phase 2 will be the new discharge to assess patient cases will receive up to 6 weeks funding from the NHS. Phase 3 will focus on the outstanding reviews for end-of-life patients, and phase 4 talks about the adult CHC team accumulating 300 outstanding reviews, which will require an assessment. So the plan is to, by the end of November, December, that we would have sorted the backlog of assessments and obviously kept on top of the new referrals that come into the service. We have to provide 2 weekly reporting to NHSCI, which we are doing, and the CHC plan, and obviously to deliver on the new referrals and the backlog, will be monitored by the Quality and Patient Safety Committee. So just to provide assurance to the governing body today that there is a plan which is really comprehensive that sits behind this, and will deliver on what we need to do by the end of November, December. Any questions?
Jamie?
Yeah, so Jane, just for clarity, I guess. So when we talk about the 104 patients who have not had an assessment during the COVID period, and obviously their support from the centrally funded NHS monies will end, and therefore they revert back to the CCG. Can I just pick, is that they revert back to the CCG unless we have done the work to identify where the eligibility fits? Because if they're not eligible for CHC and they should be funded either as self-funded or from elsewhere, would they after review then fall back to there?
Yeah, there are still some questions. There was a meeting that was held 2 days ago where there's still some questions with regards to funding that I do need to pick up with Roxana today or tomorrow. So yes, Sorry, Jamie, can you repeat the question? Sorry.
I was just thinking, I was just reading it thinking, does that mean, because we've not done the assessments over this last 3 months period, that all of the costs for those 104 patients start to become our issue from the 1st of September and the CCG will fund them? Or is it that as we work through the review and the backlog, we do the assessment and we then identify whether they are eligible for CCG funding or whether they would be, whether they should be self-funding, local authority funding or others? I guess I'm just mindful of the risk that we end up picking up the costs of people. If the assessment had happened during the period, they may never have been ours to fund.
Yeah, well, Roxanne, I don't know if you want to come in there for me with regards to the finance, but through COVID, we have been doing checklists. I think we're one of the only CCGs that have been doing those through COVID, so that we do know who are eligible or not, because we've been doing the original checklist. But Roxana, did you want to come in there?
Yeah, happy to, Jane. I think, Jane, the 104 are the patients who have triggered a positive checklist.
Yeah.
So they've not had a full DST. So we don't know whether they're eligible for services yet or not, but they have triggered a positive checklist. All the negative checklists have been kind of handed over to the council, and there were a few hundred of those people. So actually the number was much greater in terms of the caseload of the continuing healthcare team during the period. But we have case management as transferred now to BMBC. So the 104 just require a full review to determine whether they're eligible for continuing healthcare, and we will pick those people up until the point that we determine that they're eligible or not.
Okay, thanks, Bill. I think I was assuming, obviously wrongly, that the 104 was the number the total number. So these are the ones that would be likely to be eligible for CAC.
Yes. So the number was about 400. I think the number was about 400 in total.
Yeah. Thank you. Thanks, Jane. Thanks, Lisa.
Thank you. Jeremy?
Thank you. Move us on. Just one more example on health inequalities. Obviously, we had a good conversation at governing body development session about this a couple of weeks ago. So health inequalities are something, obviously, as a commissioner, we have always been focused on in turn trying to reduce them and identify and reduce them as far as we can. It's also a specific requirement within the phase 3 NHS letter. There are kind of 8 urgent actions that we have to show we are delivering against. This is just a matrix showing what we think are our priorities down the left-hand side, linking through to the 8 urgent actions. And also back to the national voices, you know, the third point in there about addressing this head on. We do have a commitment from our partners to work together on health inequalities. It's work that's being led under our Communities Resilience Cell, which is led by the local authority, but with strong representation from health within that, and supported, of course, by our intelligence unit as well, which again is a unit that's drawn from experts from across health and care. So this is something that we need to be focusing on as a CCG over the next few weeks. I think we agreed at our development session that we would bring forward what we thought were the top 2 to 4 key priorities in terms of health inequalities that we want to focus on for the next few months, and just to assure governing body that we are working our way through the evidence, both soft and hard, to support that, and we'll bring that back to our clinical forum and our partners in short order. And finally then, the governing body ask, no decisions, except for one, which I don't expect to take today, but we need to note it and make sure we take action on it. So just to note that the current rise in C19 cases nationally and locally, to note the co-production of the place reset plan, focusing on activities through to March 21, and our intention to share that across health and care partners, and obviously within the CCG in the next 2 to 3 weeks. I'll go to the last point, then come back to the next one. So transparency, consistency in communications and engagement with patients and the public, it's just so essential. And the reset plan will provide a focus for this and facilitate coordination of our place-based communication strategy. And then an ask for the phase 2 letter is that we need to appoint an executive lead for inequalities, and that's something that we need to do, everybody will need to do by the end of this month. In fact, earlier rather than later would be ideal. So that's something that you might want to consider now, or Nick, you might want to take away and just think through.
It's something that I've given some thought to, and I'd discuss it with Chris outside the meeting about who should be our exec lead. But yeah, we recognise that we do need one.
Excellent. That's the end of the presentation. Don't know if there are any more questions. But,
Jamie?
Yes, so, sorry, we're just on that last point around, you know, having a named executive lead, and we've got the thought there, but I just think it would be probably helpful as we do that, and depending who that executive lead is, Nick, but to probably have some GP clinical support to support that person as well might be helpful. So we might have a named executive, but a little bit of a sort of double act or something like that, depending who it is and whether in your ideas you're thinking a GP anyway. But
well, I'll chat with Chris about it, but certainly it needs to be somebody who understands some of the local needs and sensitivities, and therefore has to be fairly front-facing. I think the only other thing, Jeremy, that the question around this health inequalities thing is one about the fleet of foot to be able to move the resource to address the health inequalities, and that will be through the partnership working, won't it? So it will be partnership resource, not simply CCG resource.
That's right. So we need to look at this as one resource for Barnsley, the Barnsley pound, and make sure that we are putting that resource where it's required, rather than just where it has historically been.
Yeah. Okay, any further questions for Jeremy? Okay, thank you for that, Jeremy. Very clear, and got our support and all those bits. Okay.
Thank you.
So we move then item 12, flu immunisation programme. Jamie.
Yeah, thank you, Chair. So this follows on nicely, actually, from some of the things that Jeremy just referenced in terms of winter planning and the importance of getting that right. And you know, we're working with partners across the A&E Delivery Board on our winter plans. Now, one element of that is the flu vaccination programme. So I just thought it was worth sharing with governing body, and I know, you know, most people will probably be aware of the expectations, but putting that down and allowing us to have a bit of a discussion on there. So I'll just quickly take you through, but I'll assume people have had the opportunity to read. So on page 2, in terms of the flu programme, I'll just pull out some key points. So I think most people will be familiar with the eligible groups for the vaccination this year. That's been expanded. There are some new groups, some people who will be receiving the vaccine or eligible to receive the vaccine who haven't been previously. So in 5.3, I've tried to pull them out in bold, but in terms of children, previously it's been primary school children. This year, those in their first year at secondary school are also eligible for the vaccination. People who have been on our shielded list are also eligible for the vaccination. There's a bit of a sort of nuance in there, in that we are not being encouraged to use the sort of call and recall process for that group of patients to avoid sort of bringing them at risk, but to use opportunistic approach to vaccinating that group. And then towards the bottom, there's 2 additional groups. So one is, these are about staff and health and care staff, but one is around staff who are employed by hospice sector or voluntary sector in the hospices, and the second is for health and social care workers who are employed through direct budgets. So that would include people who are sort of personal assistants and other things who are supporting people on CHC. So they will also be eligible to come forward for the vaccines. So I think that's the groups that are there. I then gone on just to reiterate the ambition. So the ambition this year nationally is to achieve 75% uptake across the groups. We didn't quite get to 75% last year. So one example, the over 65s, I think for Barnsley was just below 74% last year. So we need to have a push and work forward to try and do that within the limitations. So that's for the eligible cohorts. There is an expectation for frontline health and care staff that 100% are offered the vaccination, and we're doing that for the CCG staff. So we've got a number of options for CCG workforce, which will include a walk-through facility using some of the space in Ilder House, where we're putting in place arrangements to make sure patients can come so people can come in a COVID-safe environment, in, out, and leave. So there's a number of slots for that. We're also offering a voucher that can be used at local Boots pharmacy if people prefer that option, and if people who are not coming in to work at Ilder House and it's not convenient to do so. And we've also been clear on our communication that, of course, any of our employees who are in one of the eligible groups can also access it through the routes that are available there. So we're doing our bits there. We've sent a letter out to practices this week, which talks through all of the requirements on that and sets out how we're sort of working together, and the flu planning group. So that should have come, and that sets the expectations. The one thing that that's not in this letter, in this report, but has come out since, is that there's been some information around changes to PPE requirements. So one of the things that were being picked up in terms of all the eligible groups and being able to support patients coming into practice work through, original guidance said that the use of gloves and aprons would be single use. And I think some colleagues who were here had flagged that's going to make things relatively difficult. John, you'd picked that up, hadn't you? And actually, in the way that the flu vaccination is offered, there's minimal contact. So there's been some change to that guidance, which now means that people issuing the flu vaccination can use gloves and aprons on a sessional basis. So I thought it just worth flagging that to you. So in terms of the governance to take forward the plan, just quickly, at a local place level, the expectation is that A&E delivery boards sign off the plan. We are then required to feed into an ICS, South Yorkshire and Bassetlaw planning group. So there's a flu board at the ICS, which is chaired by Jackie Pedersen from Doncaster CCG, and that group is used to then provide assurance up to the sort of region, Public Health England, NHS England, and Improvement. So that's there, and myself and Chris Lawson represent Barnsley on that. Chris actually represents pharmacists across the region rather than Barnsley, but it's been really helpful having Chris there for me. And then locally, underneath the A&E delivery board, we've got a flu operational group, which includes people from the CCG and all of our partners, and has got representation from a number of GP practices, practice managers, and others who are sort of flagging up some of the constraints and helping us to work through the current position. I've set out the objectives of our planning there at 5.10. I'll not go through those in detail. And then I guess just in terms of the approach, the way that we're doing things, 5.12 just sets that out. So there is an opportunity to work together, to do things differently across practices this year. There's an ability to move the vaccine about. Some discussions have been taking place with the PCN and out to the clinical directors about that opportunity, and to see, at the moment, our plans are looking like fairly traditional model. So practices working to deliver the vaccine to their eligible patients in the way that they have previously, obviously taking account of the restrictions and making sure that they're extending out. The opportunity to work across is still there, you know, and we'll still keep looking at that. And as we move through the programme and through the sort of flu season, if we identify any challenges, any areas with some of the specific eligible cohorts, then it might be that there's an opportunity for us to look on a different basis at how we target them and bring them in. So that's on that. The pregnant women, those who are pregnant now and who become pregnant, will be provided the vaccination through the BHNFT service, so that's covered off. NHS organisations have all got their programmes in place, so the hospital are working through with their staff, Swift doing likewise, BHF likewise, and I've just mentioned the CCG earlier. The school-based programme is kicking off now, so contact being made with the schools and the arrangement, and the Swift specialist child health team are taking that forward and are looking at ways that they can do that, making sure they've got access into schools. They are flagging that should things change in terms of pupils being able to go into schools, then that will create a difficulty in terms of their model, and they may have to look at something like they did for the normal sort of vaccination programme, where they used a big venue and booked people into slots, so they used the Metrodome for that. So they've got some contingency arrangements in place, and we have now got the community agreement. So if it's not happened already, we'll be writing out, and Swift will be writing out with their offer of support for the housebound patients. So as they did last year, but it were very late and some practices already made arrangements, that agreement is now there, which allows Swift to provide support to practices on that. So I think that's probably all I wanted to say, to put it out there and to ask governing body to support that sort of ambition to really push this year to maximise the uptake. And I think we probably said it a couple of years ago or 3 years ago when Lisa Wilkins was with us as a public health consultant and pushed, let's make this the best year ever in Barnsley in terms of flu uptake.
Okay, thank you, Jamie. John, you've had your hand up for a while.
You're on mute, John.
John?
I'm just saying that as far as the eligible people concerned at practices, all the IMS practices have had the searches sent to them, so that's relatively easy to identify the people who require the flu jab. The flying the suit at the moment is that we're now having no more than 6 people in the gathering. All my staff have had their flu jab. We've got a flu clinic booked a week Saturday. So we may be having 500 to 600 people turn up.
Hello?
Hi.
Okay, so Jamie, do you want to respond to that?
Yeah, so John, what you're saying is, just mute again, John. So I think what you're saying is, because we've got the changes now to gatherings 6 people, you know, I think that's about people going out and doing things together and closely. I don't know, so I'm getting echoing back to everybody.
Yeah, we're getting a bit of feedback on the sound. Does everyone want to try mute apart from Jamie and see if we can?
Are we there? No.
That's better, Jamie.
Is it when I'm not talking?
No, I can hear you. I can't see you. Something's happened to the screen. So you've responded to John's point.
Yeah, well, I didn't get there. What I was going to say is, I think the guidance is around gatherings.
Jamie, you're on mute.
What we need to do in the circumstances is make sure that when patients are coming in to the list, they're not coming in groups of friends, and that whatever arrangements we put in place in practice enables them to continue to meet the social distancing arrangements. So 2 meters apart and the mask or whatever else. You know, they're not suggesting that people can't come into, more than 6 people can't be in hospital services, more than 6 people can't be in schools. They're not even suggesting that more than 6 people can't be in a pub, as long as you've not sort of come together and congregating in that close group. So I think that's the issue. So I don't think we'll be told not to bring more than 6 people into practices. You're on mute, Nick, now.
Okay, Chris? Am I on mute?
Yeah, okay. Can you hear me?
Yeah, there you are, Chris. Go on. Thank you.
The ambition of 75% is almost a minimum requirement, but if you can have the best product in the world, but if you can't sell it and promote it, you don't go anywhere with it. Now, what we need really is all of us in Barnsley to promote the flu vaccination, and I'm thinking in terms of full page dot to dot in the Barnsley Chronicle, and I know not everybody takes the Barnsley Chronicle, but it will be a big start, because what people want to know is you know, the what, the where, and the when again. I think I'd like it. I think I need it, but how do I get it? I don't quite know how many people took advantage of the Tesco's and the Asda's and the Boots last year. But once, you know, you go into these places and you think, well, how on earth are they going to cope delivering that on our behalf? So I you know, we've got a lot of expectations, we've got a lot of needs, but if we aren't careful, we could hit a real brick wall unless we actually communicate this message to people that we've got a fabulous product. You need to take advantage of it. You need it. You want it. But then the question is, great, but how do I get it? That's the main thing.
Okay, okay, Chris. I've got Dr. Kadasha and Jane. So, Dr. Kadasha, you've been waiting the longest.
Yes, thank you, Chair. Just going back to the issue where we're having only 6 people can come in at point of the meeting. What we do in our surgery is we're having flu vaccination done as a drive-through program. So it's done in the car park. We have gone to set up 2 gazebos, and the patients don't need to get out of the car. We worked on the model that when you go for the COVID testing, you're given a specific time to come. So the patients are given. It starts at 8 o'clock and goes up to 6 o'clock for 10 hours. It's done on Saturday. So patients are given a particular time to come in. They come in the car. They don't need to get out of the car. They've been told to wear loose-fitting clothing, etc. So and then the windows wind down. The nurses are stationed in 2 gazebos, and they're given the vaccine. And then there's another car park where they go and stay for five minutes to see if they're having any reaction to it, and then they drive out. So this minimizes the people coming into the building, and also minimizes the fact that you can have more than, you don't have to worry about the 6 people meeting. And so that's one way of doing it. That's what we adapted to do it. We're going to do our first flu clinic on this Saturday, and we got one set up again the next week. So, and it's fully been booked. So we will see what the outcome is after the Saturday, whether it's worked or not.
That's fantastic, Hussein. One of the slight, perhaps lost opportunities, or we could refine this opportunity, is to do that sort of model on a primary care network or locality basis, because not everyone's got 2 car parks and all the rest of it, but it seems like you've got a really good setup there, and practices could instruct their patients to go there. They give the name, there won't be any particular loss, there'll be a share of the resource to do it. But the other thing that would do at a locality scale but it would take out the massive distraction to the other working of the practice, which flu vacs often are. It's a lot of capacity taken up a part of the year, and practices are also currently being challenged in the phase 3 by picking up a lot of the long-term condition checks as well. So there might be a way to model this a little bit better for some practices if they join with others in the model that Hussein's explained. So A star for that, Hussein.
Thank you. Thank you.
And then Chris, Jane.
Thanks, Nick. A really good report, Jamie, really comprehensive. With regards to the groups that are included on page 2, it was just the bottom one that I just wanted a little bit of clarification on. So, as we know, a lot of the health and workers that are employed through direct payments are employed directly by the individual receiving the funding. And I just wondered, how are we accessing those? Because these are going into our most vulnerable, or some of the most vulnerable groups in the community. So how are we accessing those that we don't directly know about?
Yeah, it's a really good question, Jane, isn't it? Because they are directly employed. So maybe something that needs a little bit more thought. The original plan. So there's a national. So it picks up Chris's point as well. So Chris, there's a national comms campaign, big campaign due to kick off. Kirsty's developed a very comprehensive plan that will include some of the things that you suggested. We're going to try locally in Barnsley to focus on. Yes, those people who have always been eligible, but those who have perhaps not been the ones who have come forward as readily for the vaccination. So just by way of example, 65 plus generally come forward. We get very close to the target. We need a bit of a push. Some of the other groups, it's a little bit more difficult. So what do we do with the parents and other people, and how do we sort of push the message of maybe not the illness that the child gets, but the risk that a child or a young person getting the flu might have on family members. So have the vaccination, protect your grandparents, sort of thing. So we're doing all of that. The national campaign, Jane, and the letters that go out will be really clear about who is eligible. So there will be stuff go out that says, if you are in these positions, you are eligible, you can go to your GP or to your pharmacy. That puts the onus on them a little bit to identify they're in that group. So maybe something for you and I just to pick up afterwards, but whether there is an opportunity for us to, because we'll know from the CHC list who are eligible for PHB. So we could potentially from that write to either those, the patients, so in some cases it might be difficult, but the patients or their family or their carer or whoever is the appropriate person to identify that people with a personal assistant, the personal assistants are eligible and where they can access the vaccine. So it might be that we could do a specific letter to target that group. So I think that would be helpful.
So that they make sure that their carers that are going in have had the flu vaccination. Yeah.
Yeah.
Sounds spot on. Thanks, Jamie.
3 people waiting to come in, I think, and then we'll move on. So there's Chris, then Madhvi, and then Nigel. Chris, please.
Thanks, Chair. And yeah, I certainly do not underestimate the challenge of the flu vax this year. So just a couple of things from me. Just in terms of vaccine availability, I'm assuming that we'll look to vaccinate our most vulnerable first, so care homes, vulnerable patients. And then I guess we'll do the 50 to 65 age group probably as the next priority. I was just interested with Hussein's innovation. It never ceases to amaze me how flexible and innovative primary care can be. But I just wonder for the 50 to 65 year group, the drive-through option might be a really good option to do something at scale if capacity is an issue. It's certainly something I know Rotherham are looking at. So just in terms of prioritisation in case of non-availability, and also whether 50-65 may be worth a discussion around doing something at scale.
Yeah, I think the 50, you're right, Chris, that's how it will work. The 50 to 64s, we've not yet got clarity on when they will be brought forward, and the expectation is that there'll be some additional guidance based on national understanding of the availability of vaccination, and it may be that there is a regionally coordinated approach to some of that, should the vaccines not actually be in general practice but be held in other places.
Okay, so
there are opportunities, but definitely that model. I was just going to say, Dr. Kadash's, sorry, Dr. Harry Cunley's point, the car park availability, it's gone further than just the practice and the availability, because actually the car parks that have been used are the council car parks, so there's been some partnership working there to free up that space and allow that to happen. So we should be able to do that on a neighbourhood basis if we so wish. Okay,
really keen to get other people in and conscious of time. So I think the next one was Madwi and then Nigel. Madwi, your hand's gone down. Do you still want to say something?
Yeah. Just to add on to what Hussein was saying, so the model we adapted is actually a one-way model, wherein we have entry from one door and exit on the other, 2 clinicians on board and 2 admin staff, and it is done on Saturdays. And there are no computers or anything switched on. Timed appointments. When patients come in, obviously admin staff just check the name and date of birth and make sure it's the right patient, and clinicians vaccinate, and they are out of the door at the other end. Just wait for 5 minutes before they go. And that's the model we have adopted, and we're going to do about 8 Saturdays, every Saturday with 2 clinicians, but across 3 sites, obviously. So that's sort of 6 clinicians, 1 Saturday model. And I think we are hopeful that within about 2 months we should be able to do most of our patients. So that's another one.
Thanks, Madwi. Nigel?
My question was regarding the 50 to 64. I think it's already been answered, Nick. Thank you.
Okay. And Mike?
Yes, I think on the model that's already been mentioned, our local practice for the last few years has always done a Saturday. And in the past, all the clinicians have been in there, all the nurses, and it's been a queue up and get your jab, and it's worked extremely well. This year, they've gone on, obviously had to change the model. They've had to go on to timed appointments, and like Madvi, they've got 2 doors. It's in at one and out at the other. And in the past, it's worked very well, and I think they've just had to slow it down a bit because of social distancing.
Okay, so in terms of a governing body, we've noted some innovation there and some opportunities at scale and a couple of different models that are happening. So we note the contents of the paper, requirements of the National Flu, and of course we support the ambition to exceed our 75%. So thank you everybody for that. Moving us on, we come to item 13, Children's Commissioning Update. Patrick, have you joined us?
I have, yes.
Welcome, just in time. Take us away.
Okay, thank you, Chair. So I will take the paper as being read, so I'll just pick out some of the key points that I'd like to raise. Firstly, the Future in Mind programme is formally coming to an end, as it was a 5-year programme, but just to assure members that we will continue to build upon the service developments and improvements that finance and investment has enabled, and we will continue to deliver the Barnsley Local Transformation Plan. Next, the work is progressing in relation to developing the Barnsley Children and Young People's Emotional Wellbeing Hub. And as members know, that the first floor of the YMCA building in Barnsley has been identified as a suitably accessible building from which the hub can operate. Currently, the IT infrastructure of the building is being updated and the areas are being made safe, and some of the painting and decorating is happening. And the intention is that when it is safe to do so, the first services will start to move into that building and become operational from there. So the first service to move into there will be Chili Pep. Quickly then moving on into respect of CAMS, and I won't do a huge update in terms of CAMS because I provided the update previously, but just to say that as members agreed, the procurement in relation to CAMS has been cancelled, and a small working group is now established, and we're looking at how we can move the CAMS service delivery from how it is at the moment towards delivering the newly co-produced service specification. And those meetings will be held usually on a Thursday, so Dr. McInnes and Dr. Smith will be fully involved and engaged within that process. In terms of mental health support teams in schools, as members agreed, we are going to go out to procure to identify a provider for the 3 teams that will be developed in Barnsley. Now, 2 of these teams will be funded by the CCG, one of them being Mindspace, which, as we know, focuses on secondary school pupils. The second team, funded by the CCG, will be a similar model to Mindspace, but will actually focus on primary school-aged children. Third team is to be funded by NHS England as part of the Trailblazer programme. And that team, again, will focus on primary school age children, but it will focus on the more vulnerable children. So those children who are looked after, who perhaps have an LD or autism, particularly the people who are educated at home, those children and people who perhaps identify with the LGBTQ plus communities, etc. So that is the focus on there. The wider Barnsley group of the Children and Young People's Emotional Health and Wellbeing Group, which includes all partners within Barnsley, are currently working together to draft a service specification. Obviously, that will be shared with members and will have the full engagement of, again, Dr McInnes and Dr Smith. There is some sort of givens really in that, because as part of the Trailblazer programme, there are a number of must-haves and must-dos. So obviously the service specification will incorporate all of those, but that will be shared probably within the next 2 weeks. In terms of the work that was commenced to implement the recommendations of the independent review of the paediatric acute services across the hospital, that work really has been delayed significantly because of the COVID pandemic. However, we're now in position to start picking up that work. And one of the key recommendations was that we developed a new service specification for the children's community nursing team. So that will be one of the priorities. And that work, it will be linked into the national work, developing services in relation to paediatric end-of-life care and palliative care services. So there has been a national service specification developed, and it has been agreed that South Yorkshire will pilot the service specification in relation to paediatric end-of-life and palliative care. But that service model is dependent upon the children's community nursing teams within the region. So that's why there's the natural link within that both those work streams. Moving on then, we have autism. And as members will be aware, last March, the waiting times on our over 11 assessment diagnostic pathway for autism was upwards of 2.5 years. So additional investment was approved, and we commissioned the service from the paediatricians at the hospital, as opposed to previously it was at CAMS. And the latest data that we have is that the waiting times for referrals into that pathway is now between 5 and 9 months. So the NICE recommendations are that the from referral to being seen, it should be no longer than 3 months. So all of the children and young people's assessment diagnostic pathways for autism are now NICE compliant, because although I stated it was 5 to 9 months, that's not the waiting time from receipt of referral to actually being seen. The 5 to 9 months is from the start to the end of the pathway. Okay, so that's a significant improvement there. And then finally, just in relation to the Children's Joint Commission services between ourselves and the local authority, and these services cover the children's continuing healthcare. It covers the care packages for children with complex health needs. It covers the services and provision for children with learning disabilities and autism, and particularly in relation to short breaks provision and the respite provision. So because of the continued increased demand for these services and the associated significant increase in costs, it has been agreed that there will be a full review of those services from both a commissioning and service delivery perspective. And so that work has started and is currently under review. So we will provide some outcomes of those reviews to members as and when it is appropriate to do so. And that's it from me.
Thanks, Patrick. Any questions for Patrick? I can't see any hands. If anybody's got a question, just speak up, because my screen's gone blank.
It's Jane.
Okay, thanks, Patrick. Just a quick question. There's a big echo. Okay, can everybody hear me without the echo?
Yep.
No. The question's about the Children's and Young People's Emotional Health and Wellbeing Hub, and reflecting on what Dr. Balash said at the very beginning about, COVID and the effect of this on emotional and mental health of young children. And I just wondered what arrangements were being made to continue to provide the services in this world that we find ourselves in, and with regards to access, availability of services and so on, because we're not in the world that we were when we set up the business case. So as things change with regards to access and availability of the use of that service.
Yeah, so within the first floor building, there's a huge sort of like training room. So the IT infrastructure they're being putting now is to enable lots of the sessions to be undertaken online through video chats, etc. So they have obviously been providing that service already in the current basis because they're based at Horizon Community College. So those services have been undertaken and they've learned from some of those elements because they are delivering it in a more effective way than perhaps they used to do face-to-face. So all of that learning has been incorporated into how they will deliver it from the base, from the hub.
Thanks, Patrick.
Nick, you're on mute.
I think our chair might have frozen.
Does Chris want to take over and then we continue until he gets back?
I think so. Chris Millington, would you be okay just to take over as chair just while Nick's sorting his technology out?
Yeah, no problem. Okay, we're on to item 14 according to my agenda here, which is you, Jane, please.
Okay, thank you, Chris. So the Quality and Patient Safety Committee met on the 20th of August and would like to highlight 4 areas to the governing body for their consideration and assurance. So the first one that the Quality and Patient Safety Committee wanted to highlight to governing body is about the safeguarding reports that have been written for the Safeguarding Adults Board and the Children's Partnership, and also the very first CCG annual safeguarding report that were provided to the committee. Quality and patient safety were assured that the safeguarding arrangements continue to be met despite the impact of COVID. And the committee also noted concerns regarding the anticipated surge in referrals following, obviously, the opening up of services. So that's the first one, so assurance with regards to safeguarding from the Quality and Patient Safety Committee. The second is patient experience. So the committee received for assurance the annual patient experience report, which is a statutory requirement and should be made available to the public. So the committee were again assured that the complaints and concerns received by the quality team were being managed effectively and that learning from the complaints that we had received had been acted on accordingly. QPSC agreed that the report provided evidence to support the CCG's annual assurance report and that it should be published on the CCG's website. The third one is LEADER, which stands for the Learning Disability Mortality Review. And this is a piece of work that has been done nationally within each of the CCGs and reviews the deaths of those people with a learning disability with a view to improve the standard and quality of care for people with learning disabilities. So QPSC were provided with a detailed update on the CCG's position regarding the backlog. Now, this is not just a backlog for Barnsley, it's a national issue, which did the backlog was increased through COVID because of the availability of reviewers. So the committee noted the progress of the completion of the outstanding reviews and a commitment to reach the set targets by the times that we've been given. And QPSC agreed that this would need to be added to the CCG's risk register because of the delay in completing the backlog of leader reviews, but also then not being able to learn from the deaths themselves. So that's was asked to be put on the risk register. And the final one, which is a red risk. So QPSC were notified of the latest position with regards to waiting times, initially for the speech and language therapy. And this came to light from a complaint that the CCG received a couple of months ago. So Swift have initiated a number of actions to risk assess all the patients, and they're working with our contracts team with regards to submitting a business case to request more funding for the service. QPSC have a concern, which we are working on, is that there is about the level of oversight to all the waiting lists with our provider, so Swift, and agreed that assurances should be sought about this issue at the next Swift Clinical Quality Board. So in a nutshell, that was a complaint that came into the CCG about one particular waiting list for speech and language therapy, but obviously it then opened up a lack of assurance with regards to the wider waiting list for our community provider. So that will be monitored and managed by the Clinical Quality Board. So any questions, please?
Thank you, Jane. Of the report, it's good to see that we've 2 in green with 1 in amber with hope for gain. My concern, I do sit on that committee, as you know, along with Mike, and we were very concerned in relation to the Swift situation, and I would hope that that would get resolved as quickly as possible. So any questions for Jane? All content then?
Nigel?
Okay, let's move on then.
Chris, could I just...
Nigel's got his hand up.
Yeah, sorry, Jane. Just on the last one. I just, it's a comment rather than a question, really. It does worry me a bit that Swift don't monitor their waiting list, and as soon as they get caught out, the first response is, can I have some more money?
Right.
And I just don't think that's the right response. I think the right response would be to fix it.
Yeah, obviously there's more detail around the whole situation, and it was a service level agreement that was came to an end with BHNFT, and then the staff changes and so on. But you're absolutely right, Nigel, that there was a level of oversight from, I think, senior management to the waiting list as a whole that we haven't had, or they haven't had, and they haven't been able to give us the assurance of that. What we have done, obviously, because of this, is to really make sure that those patients on this waiting list, because there's a significant amount, have all been risk assessed, they've all been contacted, so that we know there's a level of safety there, because there's a risk if we've got patients on waiting lists that, you know, as we know, the risks around that. But you're absolutely right, and that's what the Clinical Quality Board will really want to get to the bottom of, about them giving us the assurance that they are completely on top of their waiting list across the board.
Yeah, I suppose just as an additional comment, we are going to look at their other waiting lists. Should they all be failing as well? I wouldn't like to see another request for more finances in all these areas.
Yeah.
They must have some oversight, mustn't they, Jane? They can't function as a provider without some oversight. I think it's more likely they've dropped the ball in some areas, and possibly due to transitions. Hopefully it's not as systematic as it looks, hopefully, but we'll find out.
Yeah, we will.
Mike?
I mean, I wouldn't be that optimistic, Nick. When we were looking at CAMS, if you remember, they didn't know how many patients were on their waiting list, and when the external assessors came in, the number they came in was quite different from what CAMS thought it was. And also they had no job plans, didn't know what their capacity was. So maybe there are other issues.
Okay, so we'll unpick those. Thanks, Chris, for taking over. Anything else on Quality Highlights report? Anything you'd like to say, Jane, or any questions?
No, nothing.
So we note Mike's realism, which is realism, isn't it? Because that's the position we were in, and we'll see where we get to with that. So Jane, can you take us through Safeguarding Annual Report, please, item 15?
Yeah, thanks, Chair. So I don't intend to go through the report in any detail, but just to say that this is the first CCG written Safeguarding Annual Report that has come to governing body. And it was written to provide assurance of how the CCG is meeting its obligations in respect of safeguarding. It does provide an overview of key work streams and identifies the priorities for the next 12 months. I hope it's clear for governing body and does provide the assurance that, you know, what we've been doing, what we propose to do in the next 12 months, and equally outlines some of the measures that we've taken to support safeguarding during the pandemic. So I open that up to questions, if that's okay, Nick, rather than going through the report itself.
Chris Millington.
Yes. Jane, whose report is this?
So this was written by Angela Fawcett, who's our designated nurse for safeguarding children, and Susan Brooke, who's our designated nurse for safeguarding adults.
Okay. So, Richard, I think you know what I'm going to ask. The next one is this does this fall into the same category of all reports and needs a signature, a name and a signature to it?
Well, it's not a sort of part of our formal annual reporting process that you know, so it doesn't require an accountable officer's signature on it or anything. But I suspect, you know, it would be good practice, wouldn't it, to maybe put to put an author's name on the bottom, you know, before it gets put on the website.
We would then have consistency in our committee reports, then, wouldn't we, with the assurance reports? Yeah. Okay, thank you.
And just to, sorry, Nick.
Okay.
Sorry, and just to add that the Barnsley-wide Safeguarding Children's annual report and the Safeguarding Adults report will be coming to the next governing body. This is outside of those normal reports that we do get to give assurance to the governing body.
So one of the things, so that's good, Jane, because that's clarified the context of this. So that's useful. A question I had was over the priorities, so that there's obviously a priority around supporting COVID recovery, but I'm just not sure what, and it may be in the safeguarding, the wider report, but what the priorities are beyond that, and whether it was within the remit of this report to have those, or whether we're in the hands of the children. Is it the Children's Executive Group that do the
Children's Partnership? Yes. Yeah. I mean, they obviously both boards do have their annual priorities. But we do also, as a CCG, have our own as well that feed into that. But also what we want to do with our providers and how we can gain assurance from that sits outside of those boards. So yes, we can have additional priorities for ourselves. What we are keen to do is to strengthen even further our safeguarding functions within the CCG. We've talked in previous governing bodies about transition, which we're very keen, obviously, to major on. I know, Nigel, you've got a particular interest in the transition of, you know, of these very vulnerable individuals. So yes, they can be added to, Chair, if that's, you know, if that's what's.
I think it might be a good thing for this report in future to come about the same time as the system-wide one, and some references so we can see how they're linked.
Yeah.
And then when we look at the system priorities, we can sort of see, is there something extra that we think might need to be fed into that, like the transition of service and having the seamless pathway.
To be honest, Nick, I thought they were coming together, but I was on annual leave last week when the papers went out, so I thought that they were going to be.
Any other questions for Jane? Nigel, you've got a comment?
Yeah, it was a question. I appreciate that this report talks about there will be a surge potentially in safeguarding cases coming out after the coronavirus lockdowns were released to some degree, and I can sort of sympathise with that. My question was really whether we could be more proactive about that, because there must be other triggers that would perhaps identify these people who might not yet be in the system, but might be heading towards being in the system. And I also note some of the stuff around the county lines and gangs and knives and all the rest of it. It was just really a question about how proactive we could or are being
Yeah, we certainly are being, if I can give assurances that we are being proactive. We have already seen, before the schools go back, an increase in referrals, but obviously by the routes that would normally happen. When what we are going to see the surge is when the children return back to school and we've got more eyes on these children. So, you know, the safeguarding, reporting, the concerns, the processes that we've got in place have not stopped through COVID. We just knew that when the children, you know, go back to school, we will see the increase in referrals, but we've already started to see that.
Okay, any other questions, or are we okay to, I think we accept, was it accepted for assurance, Jane? Was that what the governing body ask was? Just have a look. What are we supposed to note the report for information and assurance, which I think we've done. Thank you, Jane.
Thank you.
So, Richard, item 16, risk and governance exception report, please.
Yeah, thank you, Nick. So you've had the paper, so I won't, in a sense, repeat everything that it says in there. I'll just pick out some key things. As far as the governing body assurance framework is concerned, I just wanted to sort of update governing body that whilst that was put on ice in a sense during the sort of the height of the COVID response, we are now actively working on reviewing and refreshing the assurance framework to make sure it's fit for purpose and accurately reflecting our priorities over the next 6 months. That refresh process will be completed by the end of September, so members of governing body can expect to see the assurance framework being reported through and updated in the usual way from our next meeting onwards. As far as the corporate risk register is concerned, again, you've within the pack of papers, you've got the full corporate risk register for assurance that that continues to be reviewed and updated. There were just a couple of things that I particularly wanted to mention there. Firstly, is that we have had a red or an extreme risk on our risk register, well, for several years now, relating to the performance of Yorkshire Ambulance Service and the potential for harm to Barnsley patients if YAS doesn't sort of comply with its performance standards. Quality and Patient Safety Committee last month, having monitored this issue over several months and indeed years, the view of the committee was that it's now appropriate to sort of de-escalate that from a red risk down to an amber risk in the light of the sort of sustained reasonable performance of YAS in terms of response times and the absence of serious incident reports indicating harm to Barnsley patients. Given that is a red risk, though, that de-escalation is just brought here for governing bodies sort of approval. And obviously it's worth just reflecting there that even if it goes from a red to an amber risk, it will very much stay on the risk register and remain under review by Quality and Patient Safety Committee every time it meets. There's another couple of sort of tweaks to less serious risks on the risk register that other committees have proposed. So Quality and Patient Safety Committee had a risk on there relating to clinical quality board meetings perhaps having become a little bit sporadic during the COVID response. I think now those meetings are very much back in the diary and are happening again, so it was felt that risk could be reduced from an amber to a moderate risk. And then as far as Finance and Performance Committee is concerned, we had a risk on the risk register relating to the transition from the previous IT and BI service provided by Embed to the new service that's provided by Sheffield CCG. Obviously, there were potential, there was the potential there for disruption to that services during the transition. The new service is now fully embedded and is working well, we think. So F&P felt that it was appropriate to remove that risk from the risk register. Just moving on, so that the comments I've just made there relate to the corporate risk register. Through the COVID pandemic, we have had a COVID-19 risk register as well, which captures specific risks relating to COVID, and that's been developed through Gold Command. The feeling is, and I think this is right, as we move into sort of recovery and stabilisation, the distinction between COVID specific risks and corporate risks is becoming a little bit of a sort of false one, really. So the intention now is to incorporate the COVID risks into the corporate risk register, and then again, so for governing bodies, sort of assurance as we go forward, you will see those reported and monitored in exactly the same way as the corporate risks. But I've listed the 4 sort of key COVID risks as we currently see them in the report for your sort of information. The next thing in my report is just around the Quality and Patient Safety Committee terms of reference. So you may recall that governing body agreed to a couple of tweaks to the membership of QPSC at the last meeting. They have now been incorporated into the terms of reference, and in addition to that, there's just been some very minor changes agreed at the last QPSC meeting around just adding a couple of reports into the terms of reference that the committee wants to see in order to make sure that it's discharging all of its functions going forward. So governing body is just asked to approve that those changes are formalised. I'll pause there, I think, to take any questions or comments, because the next bit of my report is the EPRR assurance, which I think Jamie's probably better placed than I am to take. But before we move on, was there anything about what I've said that anybody wants to pick up on at all?
I think if you just take us formally through the ask up to Jamie's point, and then we've signed it up. Is that okay?
Yeah, happy to do that now. So the ask for my bits then is obviously to review the risk register and note that all risks are appropriately scored and described. I'm asking to approve that reduction to the risk score in relation to the YAS risk. I'm asking governing body to note the reduction in score to the clinical quality board risk and the removal of the IT and BI service risk, and to approve the changes and updates to the QPSC terms of reference. So if we could just confirm that we're happy to do that.
I am, yes.
Thank you. So Jamie, could I then pass over to you to pick up the EPRR stuff? I think you're on mute at the moment.
I just can't find my button. Apologies. I've got that now. And yes, I was just saying, yes, of course you can. No problem. So I think this is fairly straightforward if people have had the opportunity to just have a glance over this. Usually on an annual basis, the accountable emergency officer, so myself, is required to work with others across the organisation to undertake an assessment against the NHS core standards for EPRR. We do that, bring that into governing body, and on the back of that we submit an assurance statement that sets out our level of compliance. We're expected then to put forward an action plan if there's areas that we need to take forward. From our perspective, we've always been either fully compliant or substantially compliant, where we've had some minor tweaks either to policy or to making sure that we do one or two things, but everything previously has been done and taken forward. Recognising the position that we're in this year, and that everybody's been in a sort of live EPRR exercise for the last sort of 5-6 months, the process has been streamlined. So we do need to submit a sort of statement of compliance, which I will draft out. But in doing that, we need to confirm that we have been through a process of capturing and embedding the learning. So we, as Barnsley, have participated in a South Yorkshire and Bassett Law learning scenario planning event this week, and we're planning to do something within the CCG through the sort of silver group, whereby we review our response and the actions that we've taken through COVID against our sort of EPRR policy, as we would when you step down an incident. So so I will do that. So it's just to make people aware that we will need to do it. I'll be taking that forward. The deadline is to do that by the end of October, so we've got time to do that. What that doesn't give us an opportunity to do is to bring the sort of statement and information back into governing body for sign off. So what I'm asking is, I guess, whether that can be submitted by me confirming that we've done the things that we need to do, so that we can meet that deadline. And I can circulate around to everybody what we've submitted. It will just be a simple statement.
Okay, so are we happy with that? Yeah. Screen's gone again. Can you hear me?
Yes, we can.
Okay, you can't hear me. So if people are happy with that, we can complete the governing body asking, note the arrangements, assurance process, and that Jamie, as AEO, will submit the response by 31st of October.
Yep.
Okay, that's great. Thank you, Richard. Thanks, Jamie. So we move to item 17, integrated performance report. Roxana, do you want to take the financial update first, and then Jamie can share with us some points on performance?
Yes, thank you, Chair.
Thank you.
So I'll take the report as read, just a few highlights for the governing body to note. So the CCG has received a top-up allocation of to month 4 of 8.3 million, 3.2 of which related to COVID-19 expenditure, and 5.1 million non-COVID. This allowed the CCG to then achieve financial balance, which previously, given the fact that we're in a retrospective top-up situation, meant until the point we received the allocation, we were not delivering one of our financial duties, but we are able to do so now. Top-up arrangements are expected to continue for at least until the end of September. There have been some indications coming through planning forums that may continue for a further month into October. Because we've still not yet had the full planning guidance for month 7 to 12, and still no indications as to when the CCG is likely to receive its resource allocation for the period October to March. So clearly some significant risk in that for the CCG. Likely to be some significant challenge around affordability, and there may be some efficiency requirements during the year for commissioners and providers, and the longer that time progresses, that clearly is more difficult to deliver. So conversations are being carried on with accountable officers, chief finance officers, and also at the health executive group, which is part of the ICS, because as governing body are aware, the allocations for months 7 to 12 are likely to go through the ICS to each individual places and organisations. A couple of other points to note. So included in the report is a little bit of detail around some of the guidance we've received in relation to phase 3, particularly in relation to how providers will be incentivised or not to deliver certain levels of activity, and those are noted in the report. And as Jamie referenced earlier around planning, we've already started working with the providers around what their activity plans look like for the remainder of the year, and what that might mean in terms of them receiving an incentive or a penalty against their contract for this financial year. Main areas of concern within our forecast position continue to be the ones that we've historically seen. So those are within prescribing, where we've seen significant cost pressures, particularly in relation to CAT-M and no cheaper stock. The other pressures around the fact that we've not been able to deliver the full QIP requirement that we normally do in prescribing. So historically we have a QIP of around about 4 million. Currently the position only assumes a QIP delivery of approximately 2 million, which is essentially the carry forward from last year. So it's the full year impact from last year's financial position. Other pressures include complex cases and continuing healthcare. we had quite a significant conversation about this area at Finance and Performance Committee around assurances around the processes and making sure we are have a robust process in place around case management and ensuring that we are only picking up costs as required and that we're not getting pressure from providers, and I mean our contracted providers as opposed to the independent sector care providers. Clearly the market's a challenging one for care because we are sometimes held to ransom in terms of the care market and the rates of care that are charged by providers. But I am working closely with Jane in order to kind of ensure that we've got a robust plan in place, that we understand the position in Barnsley, and that we are clear that we are meeting our statutory obligations actually in terms of providing the care that is needed for those patients. Other areas that are included in the report, but these are just for governing body to know, are the COVID costs that were included in our claims. So the report includes the claim that we made to NHS England. It also includes costs that we have approved at CCG Gold Command in relation to COVID, but have not yet been claimed.
Okay, thank you, Roxana. Any questions for Roxana? No? Okay, so Jamie, do you want to say a little bit about performance?
Yeah, I'll come in on that. I think similar to last time, a condensed report. We've referenced over the last few months that clearly due to COVID that performance has been impacted in a different way and is different to where we would expect. You've got the dashboard which is attached with just the main sort of indicators, and now we're just going to pick out just a few of those. And I think it reflects what we said last time. So because of the restrictions we've faced over the last few months, the ability to bring patients in areas where there are waiting times are the ones where we can see there's a continued sort of issue and a challenge for us. So just picking out some 52-week waits, so patients waiting more than 52 weeks for treatment, always been 0 or very close to 0 in Barnsley. There's 37 patients waiting as it currently stands. The expectation is that this will continue to increase a little for the next couple of months, but because of capacity that's been put in place, the expectation is that by the end of the year that will be resolved and there'll be no patients waiting that length of time. On the back of that, you can also see a sort of downturn, continued downturn in terms of patients who are seen and treated within 18 weeks. So again, usually positive, but we're now only seeing 60-odd% of patients within 18 weeks. So people are on that waiting list, waiting longer. When I presented last time to governing body, we were seeing some issues around cancer performance. But I think I was flagging that because of reduced people coming forward, a reduced level of referrals, that actually performance against the 31 and 62-day targets wasn't affected as much. What you can see this month is that actually we are now seeing performance against them two measures waiting, so people are waiting longer following referral until their treatment. Just as they work through that backlog, and as Jeremy referenced in the COVID item earlier, there's a clear plan to resolve that and identify how we do. But at the moment, we're still seeing that position. 2-week waits. The hospital and other providers are managing to sort of see the patients, do the assessments. So it's the process after that that is seeing the delays. It's probably worth picking out A&E. Usually have a conversation about that, and I guess just to reflect that we are seeing the numbers coming back into A&E, high levels of acuity, so people who are coming in who are really ill, which is therefore having an impact on performance. So I think a combination of acuity in there, and also the restrictions and the limitations on space that mean that they have to work in a different way. So we have seen performance there dip. And then the other one, I guess, I would just pull out, and it's still showing as red. If you look at the sort of bars around the sort of IAPT access rate, they are reducing. We're getting closer to the target. The access level is improving, but we've still not got enough activity coming in and enough new patients being seen in the IAPT service to achieve the national standard. We do expect, and we've submitted details jointly with SWIFT into the plan that will recover, and actually the capacity that's in place, utilisation of different models, including digital, will allow more, subject to them coming forward and referrals coming forward, more patients to be seen to get us back on track by the end of the year. That's all I wanted to pull out, Chair.
Okay. Any questions for Jamie on performance? No, and therefore do we feel comfortable we've done the governing body ask? So noted the performance.
Sorry, Nick.
Yeah.
Jamie, are you aware that IAP are not taking referrals anymore from patients who are phoning?
No. So should be taking self-referrals. My understanding is that referrals are still coming through. So if you're flagging that, John, I will raise that with Patrick and get it picked up straight away. Because
I've got about
taking
3 or
referrals.
4 who've said that they're not taking referrals over the phone. You know, they've given these little leaflets to hand out to patients with the numbers on, but it seems that they're not taking them on the phone. That's what I've heard from some patients.
Okay, we'll pick it up because that's the way that we're aiming to increase the referral rate. So
yeah,
we need to do that. Yeah.
I've not heard that, but I have heard that it's increasingly difficult to get through. So we just need to look into that, because they should be accepting, and avoiding face-to-face is part of what is a large part of their work anyway. And looking at the COVID-related mental health morbidity, IAPT is a place that I'm fairly sure will be inundated.
Yeah.
Okay. Thanks, John. Any other points? Okay. Thank you for that, Roxana. Thank you, Jamie. So we move on to a series of committee reports. So Membership Council, 11th of August. I wasn't there. John was. These are unadopted. They're still a draft. Essentially as read, unless anybody's got any particular points that John can pick up. No? Okay. So we move to 18.2, Finance and Performance, held on the 2nd of July. They're there for information and assurance. They've been approved. And then we move on to, if that's all right, with the governing body's permission, to 18.3, Assurance Report of a Primary Care Commissioning Committee, which I know will be a concise report. Chris.
Yes, quickly as possible. It was agreed that we would highlight the situation with CQC. The CQC have paused their routine inspections during COVID-19. However, their regulatory role and core purpose of keeping people safe has not changed. Highlights as far as they're concerned, and what they're doing is they're using and sharing information to target support where it's needed most. They claim to be having an open and honest conversation with people. They're taking action to keep people safe and to protect people's human rights, and they are capturing and sharing what we do. So in relation to anybody out there in Barnsley who will look at this recording, the CQC are doing the job that they're there to do. In relation to Barnsley, a couple of practices were noted, which was Rose Tree. That resulted in an assessment that they were managing well during the COVID pandemic period. There was a concern regarding Dodworth Medical Practice, but when they actually looked deeper into what they were looking at, they realised it referred to the previous owners and not the current fantastic work that's being done there at the moment. And the third item that came to our notice was Caxton House surgery, but that was deferred because, as we're all aware, that Dr. Saxena had submitted an application to actually cancel her CQC registration due to her impending retirement. And that's the complete one from primary care.
Thank you, Chris. Any questions for Chris? Okay, so we've got minutes of the Quality and Patient Safety Committee that have been adopted from the 2nd of July. Anything else to add, Jane?
Nothing, Chair, no.
And then 18.5, the Equality and Engagement Committee Assurance meeting 13th of August, which includes
yes.
the meeting of the 20th of Feb.
Yeah, always a very busy agenda on this particular committee. The headlines from our August meetings were all about the National Voices and their letter and their ask, which we've already covered. Workforce race equality standard data. Within the papers, you've two appendix, which I'm sure you've read, I hope you've read, which talks about adoption of the quality and engagement minutes of the 20th and the unadopted minutes from our August meeting. There are 8 areas within those papers that cover the discussions, and I'll just headline them to you, such as the rainbow badge scheme. I normally wear mine, but I've got a different one on today. That's now being rolled across the Barnsley Hospital, South West Yorkshire Partnership Trust, all our GP practices. We covered our zero tolerance policy. We covered Be Well at Work, which we're working towards. As I said, this committee always has a very busy agenda and the minutes can be quite copious. Happy to accept any questions.
Any questions for Chris? Okay, that's good. Thank you, Chris. Thank you for that. That's the end of the committee reports and minutes. We now have a section of minutes which are here from the ICS, which were sent in advance for information. I think the best way to take these probably will be to assume that people have read them, and if there are any issues that they want to discuss, to pick them up here, or if they feel it's more appropriate outside governing body. Is there anything that anybody would wish to pick up? No? Okay, so that brings us to the end of this governing body meeting in public. We have a section where we reflect on how well the meeting's business has been conducted. I think we've got through the business in a timely and informed way. 1 or 2 IT glitches, but otherwise I think things are fine. If anyone has any training needs they've identified, then come and speak to me or Chris Edwards. And so thank you. We'll close the meeting there, and with the governing body's permission, we'll do the private meeting with exclusion of the public. So also say thank you to the public who will see this and for their continued support, challenge and feedback. And of course, to big thank you to Kay, who's been minuting this, and we couldn't work without her. Thank you, Kay. So at that point, we'll close the meeting. Private is down for 12:30. Do people want to come back a little?